हेलो 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 सर, आवाज आ रहा है?
यस यस हाय
ओके।
ऑडिबल।
वन सर।
वो जब तक आते नहीं है डॉक्टर साहब तब तक स्क्रीन पे कैन वी हैव दैट इनविटेशन वाला टेम्पलेट गोइंग ऑन?
वो मैक्सिमम है ना?
नहीं नहीं ये नहीं,
तो
सलील बेंद्रे साहब का एक बनाया ना हमने।
हेलो दीपेश। हेलो
अरे आएगा आएगा करके।
दीपेश। हेलो हेलो हेलो
हेलो
afternoon, everybody. And we're live now, I presume. So, um, today we're all gathered here for a wonderful medical session. And this is part of our drive called NEP, Nation Against Pneumococcal Infections. And this is with regard to our vaccination, that is the pneumococcal polysaccharide vaccine, the 23 valent. And today we are going to discuss adult pneumococcal vaccination, specifically in respiratory ailments pertaining to chronic lung disease. Our focus will be more on COPD and also on asthma. And we have a very, very esteemed and extremely popular speaker with us today, Dr. Salil Bindre. I think there's nobody who doesn't know him. And we've also seen him all through COVID, how much he helped us and educated us. And I have myself attended so many of his sessions and been really privileged to work with him. So thank you, Dr. Salil Bindre, today for joining us. And especially since we're in a
Thank you.
post-COVID era now, we have seen the impact of chronic lung diseases and not being vaccinated, what it can possibly do when suddenly we are exposed in a pandemic situation. So I think this is a very apt time for us to discuss adult vaccination. And this is a segment of the population we really tend to ignore, because our focus is always on children, and the parents are always very sure that their children get vaccinated, but they forget themselves. So this is a good time for us to visit adult vaccination, and in pertaining to pneumococcal pneumonia, as well as invasive pneumococcal disease, specifically in those who are already vulnerable because of chronic lung disease. So Dr. Salil Bendre is attached to Nanavati Hospital and KLS Hospital. I mean, everybody knows him. He is on the committee of so many associations. He has been part of so many papers, so many consensus documents. He is an authority when it comes to chronic lung disease. So thank you, Dr. Bindre. It's going to be a great educative afternoon for us. I hand it over to you to take over from here.
Yeah, thank you, Varsha. That's a very nice introduction. Thank you for those kind words. And it's my pleasure to be associated with your organization. And I have been knowing you for last so many years, and you have been very academically interested, always, reaching out to the newer updates, newer guidelines, and whatever is happening in research. So it's definitely a pleasure to be associated with you and your team. And I welcome all the doctors who have joined us today. And yeah, we will be discussing about pneumococcal vaccination. Somehow, vaccination still takes a backseat when we talk of adults. And as you rightly put out, we definitely go ahead with the vaccination schedule in the children. In fact, we never want to miss even one vaccine for our child, may it be the DPT or a booster, or but when it comes to having an adult vaccination program, there is a lacking either in the awareness or the need of a vaccine, or understanding the impact of a vaccination can have on a respiratory ailment. My dear colleagues who are the pulmonologists, I am sure that they must be advocating vaccination to all their patients of respiratory diseases. Why I'm using the word all? Because we see so many, even in the younger age group, having repeated lower respiratory tract infections or getting admitted once in a year or once in 3 years. Even younger asthmatics who get admitted with severe lung infections, and of course those whom we are treating as lung fibrosis or chronic obstructive pulmonary disease, and in our city even post-infective bronchiectasis. So we have got a huge number of patients who get admitted. Of course, many of them get better, but at the same time, there is a high mortality rate if the patient lands up into an invasive pneumococcal disease, which forms a big number of patients, because we very well know that when I am treating a patient with community acquired pneumonia, or any of the physicians are treating with a patient of community acquired pneumonia, we are actually talking about Streptococcus pneumoniae as a common organism in all age groups, especially in the younger age group without any comorbidity or without any prior lung disease. At the same time, it's a fatal disease to happen in a patient who is a diabetic, in a patient who is an elderly person, in a patient who is an asthmatic, or in a patient who is having a chronic lung disease. So if you ever gauge to check whether he has an invasive pneumococcal disease, then it's in terms of percentage, significant number of times, that is almost adults with chronic lung diseases are associated with 6 times the risk of invasive pulmonary disease as compared to healthy adults. So that you can itself gauge as how severe it is, how frequent it is. Though we are always worried about a gram-negative infection, we are always worried about an Acinetobacter or a Pseudomonas, but we should be also understanding that Streptococcus pneumonia has a vaccine. The other gram-negative organisms do not have a vaccine till date. So if we are having a vaccine to increase our immunity, to boost our immunity, to reduce the severity of this infection, then I suppose we are the ones who are to take the blame if we don't advocate it to our patients. And the it's never a thing that the patient is not ready for a vaccine. The first thing has to be come from the doctor to advise it. In our practice or in my practice, once you start using it regularly, you will find that almost 90% of your patients get vaccinated and they are ready to take vaccines. So we have got incidence of these pneumococcal pneumonias in adults with underlying conditions. And you can see the age group. As the age advances, say above the age of 55, above the age of 60, it is a huge increase in the incidence of pneumococcal pneumonia. I'm sure that all of the people who have joined us today have admitted patients of pneumonia, have treated patients of pneumonia, especially the elderly age group. And if at some point we have not told this patient, even at discharge, that we should take a pneumococcal vaccine, then the onus lies on the treating physician as to why it was not advocated. Not because it will stop the pneumonia from occurring second time, but it will definitely reduce the severity of the infection. So at all age group, across all age groups, it's definitely a higher risk in patients with chronic lung diseases. And coming to community acquired pneumonia, in the community today, we are seeing an onslaught of viral infections. Then it may be a viral influenza infection, it is a respiratory viral infection, respiratory RSV virus. At the same time, not to forget, atypical organisms like Legionella and Mycoplasma, and of course, Moraxella catarrhalis. At the same breath, I would also say that pneumococcal pneumonia is one of those organisms which can lead to bacterial meningitis, it can lead to sinusitis, it can lead to bronchitis. And in children even, there is a very high mortality rate if they develop a bacterial meningitis. So we need to be careful about this. We need to understand that it's the second most common reason of death from infectious disease in our country. And it's a data from Mumbai which talks about it. It's not the Western literature. Whenever we talk about data, generally we say that, okay, this is from the Western world. We cannot compare it from the Indian data. But here, when we talk of a data from our own country, community acquired is the second most common reason of death. 36% of isolates of community acquired pneumonia are Streptococcus pneumoniae. And 40% of all of them have invasive disease. So you got to see there is a significant burden of adult pneumococcal disease in our continent. And the Indian subcontinent, it contributes the largest share of the pneumococcal disease burden in Asia, which is an eye-opener to all of us that we need to take steps to curb this disease or to reduce the outbreaks or prevent the casualties which are occurring. And obviously, since it's an airborne infection, from COVID, obviously, we came to know how severe and how dangerous an airborne infection can be. But all pneumonias or respiratory infections, for that matter, are going to be transmitted to others. So if I have a streptococcus resistant organism and it's going to be infecting two other in the house, and one of the elderly persons in the house gets infected, he's going to be at a higher risk than the individual who is having immunocompetent body. So people in the house, you must be seeing one patient comes and it's like the trigger, and then there are three people in the house who get infected. They are coughing and they are having fever. And unfortunately, out of those 4 people, the grandmother, who is 88-year-old or 84-year-old and who is a diabetic, lands up in the ICU with a respiratory failure. And the reason was that that lady got infected from infection in the house, and she was unfortunately not vaccinated, though it was told and though it was advised. Even patients don't take vaccines regularly. For that matter, even if we talk of a flu vaccine, if I tell them annually, they skip 2, 3 years. Whenever they get an exacerbation, they'll end up and say, can we take the vaccine now? That's the ground reality which happens. So, though it's a common infection, we very well know that there are other infections to come hand in hand. That's Klebsiella, there's Streptococcus, of course, and many of these are related to COVID and post-COVID. Our patients' lungs post-COVID, those who are having moderate COVID, those who had, like those who are in the ICU, those who received steroids, those who had those CT scan pictures showing ground glass, they are the ones which are the most prone to develop lower respiratory tract infections. So we need to be careful for them as well. They need not be ILD, they need not be fibrotic, but they are having a lung disease which was a post-COVID. So important lessons we need to sort of learn from these disease outbreaks. The for fatality rate of COVID, elderly people, huge number of people succumb to that disease. Same is true with any fulminant infection which happens in our community. So pneumococcal pneumonia, just because it's a very common disease doesn't mean that it can have common outcomes. It may be uncommon outcome. It may be an invasive pneumococcal disease which we never know. And we have to understand that airways are to be protected. We can't stop breathing air because it is infected. We have to only immunize our body. So there are many immunomodulators which are available in the market. There are flooded with them. There are different formulations, different combinations. Few data are there, few studies are there. Sublingual immunotherapies which are into the market. We need to stand by what has shown as a robust research, which has got backed up with a lot of data, and stick to that plan of action. Spurts of papers or few of the reports doesn't mean that they are the best of the lot. So vaccination has been held itself for a long time. It's a world recommended way of treating, and the WHO and the parent organization, they are very significant. The clinical bulletin which talks about the clinical guidance for these patients are even recommending adult pneumococcal vaccination, even during the COVID times. So that's the time, and post-COVID, we should be surely and certainly going ahead with this recommendation which talks about the adult immunization schedule by the age group. And this is as latest as the 2022. And it is by the CDC guideline, where you can see in the red block about the PCV 15, PCV 20, and the PPSV 23. Today, we are obviously talking about the PPSV 23, that is a vaccine, which talks about 1 dose of PCV 15. Now here we are mentioning specifically PPSV 23, which is available for us. And you can see that block is all age groups, right from 19 age to the elderly age groups, everywhere it is mentioned, just to make it as a very comprehensive and a very specific table. You can check here about the for healthy adults, the advisory committee on immunization practices. Okay, the advisory committee talks about age group 19 to 64 and talking about the PPSV 23 and the PCV 13. More than 65 years, 1 dose recommended. So this is one of the recommendations which has come. Obviously, as pulmonologists, we will stand by the Indian Chest Society guidelines, which talked about a white paper which came up and talked about the recommendations which came in. Those with chronic comorbidities. Okay, again, here we have got in age group, the younger age group, 19 to 64. So if you just think about your patients, 55-year-old bronchiectasis, 45-year-old ILD patient, or a 64-year-old patient with COPD, or a patient who is obese. I'm sure all of us see patients who are comorbidity like obesity. They are diabetics, they are hypertensive, they have got sleep apnea. Today, sleep apnea is such a common ailment, I should say, that all of them should be vaccinated, because one of the most important reasons for a patient with obesity to succumb to respiratory ailments is a respiratory infection. It is not the obesity itself. And it's a very strong comorbidity to chart the outcome of this patient. So we have to consider even that as a very important comorbidity in our group of patients as a pulmonologist. They may not be asthmatics, they may not be COPD, but they have obesity and obesity sleep apnea. So even they are those who should be vaccinated. And if you really start vaccinating them, they are going to do nothing but thank you for that. And they come back to you asking that should I take the next dose? When should I take the next dose? When should I take the booster? And can I vaccinate also my sister who is there in this particular state? Or those doctors have not asked me to get vaccinated. Should I request them also to get vaccinated? That's how the chain of vaccination is going to move on. And that's how you will be known to be a doctor who not only advises treatment, but also puts much efforts in the preventive aspect of a respiratory disease. So it's very easy and it's perhaps very standard for us to talk about the treatment of pulmonary disease. But preventive pulmonology is something which is not put so much attention to. And preventive pulmonology implies vaccination. It implies pulmonary physiotherapy. It implies nutrition. It implies yoga. It implies meditation. It talks about using a mask. So many aspects come into preventive pulmonology. So before you become a pulmonologist as a treatment or ICU or a critical care, you should also be having some focus on the preventive aspects. And so coming back to that recommendation, which talks about a single dose of PPSV 23 is recommended for routine use amongst all patient aged 65 and above. And it also recommends those in the immunocompetent adults with underlying conditions like diabetes, chronic lung disease, liver disease, for that matter, smokers or alcoholics. Even they are to be given this vaccination because at the end of it, they are all going to come back to us with severe fulminant infections. There may be aspiration, there will be community acquired pneumonias, repeated LRTIs, and they keep on passing it from each one. So there is strong evidence to talk about how is which serotypes coverage should be given, broad serotype coverage of PPSV 23 specifically, and how it improves as we go on with the age also. And the effectiveness of against this particular vaccine type has been proven beyond doubt in this Cochrane meta-analysis, which talks about an 82% effectiveness against this particular type of invasive pneumococcal disease. And there is another meta-analysis which talks about a 73% efficacy against invasive pneumococcal disease. So when we talk of efficacy, it takes into consideration the severity and the mortality or the morbidity. It doesn't talk about completely not getting that infection, because many patients have a myth in their mind that if they are vaccinated, they should never get a pneumonia, they should never get an infection. So it's never going to be aimed at not getting an infection. It will be always aimed to prevent a severe form of infection. And that has to be going into their mindset right when you advise vaccination. So there are these 3-year follow-up of the CAPMS study, which again talks about the effectiveness of invasive pneumococcal disease and against the bacteremic pneumococcal pneumonia, non-bacteremic pneumococcal pneumonia. And the studies have shown it's more than about 21,000 subjects. So we can see the extensive data which we have to talk about it. And a randomized non-placebo controlled trial, which was done as an Indian study between 2013 to 2015, it showed a 32% reduction in the exacerbations as compared to the control group. So if you talk of exacerbation, I think today there is no question of asking how much is the cost of a vaccine. Unfortunately, we'll end up considering, should I vaccinate? It's going to cost me 2,000 rupees. It will cost me 3,000 rupees. But one hospitalization of a patient to a tertiary care would easily mean anything around 1 lakh to 2 lakhs, depending on what is the stay of the patient in a hospital. And vis-a-vis, if we talk of a vaccination, perhaps to reduce his stay, perhaps to not allow him to go into an ICU, then that would save a lot of money. So decrease in the exacerbations, decrease in the severity, all have been proved beyond doubt. And again, there is always a confusion or a comparison between what is this PCV 13, what is this PPV 23. I think we have got a very learned audience to know about the serotypes, which are the PPV 23 contains the 23 serotypes, of which 11 are unique, very specific. And that's how they cover a broad coverage of the pneumococcal strain which is present. So we have got the PCV 13, as you all know, it is there. It's conjugate vaccine, and the PPSV 23, which is a polyvalent vaccine. It's a much broader coverage, and 80% of the invasive serotypes are included in the PPSV 23, and that's where it highlights the aspect that why we are discussing today at all about PPSV 23, because it's definitely a disease which is very commonly seen, and it's the serotypes are involved. 66% is the coverage offered by the PPSV23, whereas 48% is the coverage offered by the PCV13, is caused by these particular serotypes. So we are trying to insist on this, that we need to consider PPSV23 as a very important vaccination in terms of a pneumococcal vaccine. And PPSV offers coverage to all the 5 most common serotypes across various clinical syndromes and comorbidities. Correct? So age groups, yes, very important. Chronic lung disease, very important. Giving a good coverage with a maximum number of serotypes is equally important. So COPD asthmatics is very, very important that they should be vaccinated because they are at the highest risk of developing a community-acquired pneumonia. And we know streptococcus pneumonia is a much, much more common, almost 43%, which is a huge number of patients of community-acquired pneumonia. And the patients of COPD have 8 times higher risk of hospitalization due to pneumococcal pneumonia. So and every infection for every patient is a setback. It's a setback in terms of the lung disease, it's a setback in terms of some fibrous tissue being deposited. And it is a welcome for the next infection to come in. And it's also going to give rise to a lot of loss of the work hour loss in these patients. So risk factors in COPD patients, as we talked about, elderly, of course, emphysema, where the lung capacity is significantly low. And one of the factors you can see here is the high BMI. A BMI more than 22 is a risk factor. And we have got a good number of patients who have overlap of COPD and obesity. Okay, so there are many of them are the phenotypes which are chronic bronchitis. They are obese, okay, and they are flatulence, and they have got pedal edema, right heart failure, pulmonary hypertension, cor pulmonale. So many of these factors happen together, and we should be putting our step forward to getting it controlled. So pneumococcal vaccination provides significant protection, reduces the likelihood of an exacerbation, and reduces the community-acquired pneumonia in a patient with high-risk COPD. Right, so it reduces hospitalization itself by itself. Definitely talks a lot about it. And coming to the diabetes COPD link, I am certain our patients of COPD have almost 15 medicines ongoing. There is a cardiologist who is seeing the patient. There's a nephrologist who is seeing a patient. There's a dietitian who is seeing a patient, and of course the pulmonologist who is going to be seeing the patient. So you have got so many diseases. We know very well there's a lot of patients who are having osteoporosis. And diabetes and COPD comorbidities coexist in a large number of patients. So if you have these patients, which I'm sure you have, I would say that 70% of your patients of COPD would be hypertensive or diabetic or cardiac. So all of them fall into that criteria where we can vaccination, because that's the best way to prevent the diseases from coming in. And here we have got the Indian data as well, where we have the immunocompetent person and the immunocompromised person. So in immunocompetent, routine vaccination for 50 years of age or older, persons aged more than 2 years with cardiovascular disease, chronic lung diseases, diabetes mellitus, and immunocompromised patients having HIV, lymphomas, patients on chemotherapy, patients on long-term steroids, patients with nephrotic syndrome, patients who are obese. So multiple factors which come into play when we think about should we vaccinate or should we not. And over 90% of unvaccinated adults with invasive pulmonary disease, pneumococcal disease, had missed their vaccination opportunities. So which is the best opportunity time to start vaccination is right now. It is not about waiting and considering if they get an exacerbation, I will vaccinate them, or I will vaccinate them in the follow-up. I think it should be a part of the prescription. Vaccination should be a part and parcel of that entire management protocol which goes into place. There are a lot of hospitals who have now a vaccination OPD. I think every clinic should have a vaccination facility available, because when you advise vaccinations and patient goes to their homes, many of them lose out the seriousness of it, the importance of it, and maybe 20% or 30% stick to that advice. Whereas if you have it at the clinic itself, then of the clinic with the vaccine in place. Unfortunately, less than 14% of diabetic patients have shown to have been vaccinated, which is definitely very less. And only 4 of the 28 physicians treating these patients prescribe vaccines regularly, which is not a very great number to talk about. So there is a serious need to improve the adult vaccination rates, immunization rates, and that is one place where the companies like them who are helping us with come together to create more awareness. That's where our main job is to percolate this information and use it and apply it to our patients. So there is lesser focus, and we need to improve the coverage, which is very, very critical, because that will be stopping the comorbid, the infection, the severity, and the spread in the community. Finally, we are looking at a community as a whole, not as one patient. So if I have a patient who is a COPD patient, and he goes back in the community, infects 4 other people, they are going to infect others, and they are going to infect others. So if I try to control one patient, that is going to be multiplying to a large extent. The hospitalization is going to be reduced. Cost stay is going to. Today in molecular families, let's apply it in practice. One person gets admitted, 2 people are working, they are just not able to sort of stop their work, because it's like a very time bound schedule, leaving in the morning at 8 and reaching home by 10 p.m. And 1 day leave and 2 days leave, and one person gets admitted, the entire household is in difficult array, there's a disarray. They can't do that. In fact, they can't afford to do that. And if you even think about some idea that it can help to prevent such episodes, and this kind of an understanding is given to the relatives, given to the family, they are much encouraged to take this vaccination. So you have to have a good immunization schedule. You need to provide a strong recommendation, administer the vaccination better at your own place or your clinic, or make it a rule that at discharge, take vaccination and go. There is nothing which says that you should not vaccinate when the patient is getting discharged, or you should vaccinate after 10 days or 15 days. So it's no such rule which is there. So that is the best time to vaccinate them. And if you can manage to vaccinate them every time, keeping a chart or a diary, they do come back themselves, asking you, now is the time for my next vaccine. So the key is actually to talk about when to vaccinate, how to vaccinate, and emphasizing the importance of this vaccination which happens. I think if we should have conviction in what we advise. That's what lacks. It shouldn't be that because I read one lecture, so I wanted to vaccinate, or because I read about it sometime, that's why I should vaccinate. It's about how much one is convinced. If you are convinced about doing a spirometry in your asthmatic and you are advising them regularly, then it's the same conviction which you should carry when you are advising a vaccination. It's the same conviction you should carry when you are advising them physiotherapy. And that is what will be moving on to the patient. Patients accept much easily and much clearly if the doctor advises them with conviction. So I think everyone is a learned audience here. I don't really need to emphasize that point, but it was just to make everyone understand the seriousness and the lack which we have amongst our vaccination programs. So I thank everyone, and I thank Varsha and her team for inviting me for this session today. Anyone wants to have an input or a suggestion, I would be welcoming that.
So, thank you so much, Dr. Bendre. As usual, it was a very insightful talk, and I think some pearls came out from your own experience, especially about doctors having to advocate it with conviction. I think that was a beautiful conclusion and a very important one. And another very good thing you said is vaccination at discharge. I think, Dipesh, that's also a very good point for us to note that all patients admitted for chronic lung disease, when they are being discharged, must be given the vaccination, the best time to vaccinate. Very good point emerging. So, Dipesh, would you like to see for any questions, if we can take them up, or anything in chat before we close the session?
So no, right now we have no questions on chat here because we were live on another link. And so as and when the
Okay.
queries come, we would compile and share it with you and Dr. Bendre sir.
Excellent. So, Dipesh, I think you can do the concluding remarks and close.
Sure. So thank you, Dr. Salil Bendre sir, for joining us and creating more and more, I mean, the more and more awareness about adult vaccination. And I remember, sir, when we met the other day, it was only 5 minutes that you took and said, okay, yes, I am ready to make sure the knowledge is imparted to maximum people. And today we were,
Dipesh, you're on mute.
yeah. So, sir, thank you. I mean, for joining us. And I remember when we discussed about this, we were, I mean, within few seconds, you said, yes, I'm ready to impart knowledge to maximum doctors. And today, sir, 70 plus doctors have joined us who are from different parts of the country. And I mean, still people are joining right now. Here only on my screen, I can see there's 74 people. So thank you very much, sir, for joining us. And we would like to collaborate with you more and more for creating such kind of awareness initiatives. And we'll meet you, sir, again. And thank you once again, sir. Thank you very much.
Thank you.
Thank you.
Thank
Thank
you,
you all
Varsha.
of you. Yeah.
Thank you.
Thank you so much.
Bye bye.
Take care.
Tag team end the meeting.